Embryology. The thyroid gland originates from the median and lateral thyroid enlarged, the embryological precursor tissues, which follow separate embryological paths prior to fusing and forming a single gland. To speak about the median thyroid enlarge, the primitive pharynx begins to form the median thyroid enlarge starting at the second week of gestation. This structure appears as an epithelial proliferation in the floor of the pharynx between the tuberculum impar and the copula, arising at the level of second branchial arc. As it descends towards the primitive heart, the median thyroid enlarge becomes a bilobed diverticulum with a median tubal structure called the thyroglossal duct, which keeps the structure connected to the tongue. The thyroglossal duct becomes a solid structure in the 5th week, after which it fragments and disappears. The obliteration of this structure leaves the foramen cecum at the base of the tongue superiorly and, when present, the pyramidal lobe inferiorly. So it is not always present. The thyroid continues to descend to its final position anteriorly to the trachea by the 7th week. The cells derived from the median thyroid enlarge arrange to form follicles and produce thyroid hormone by the 10th week of gestation. The lateral thyroid enlarge arises from the pharyngeal endoderm and fuses to the median enlarge at the 5th week during its embryologic descent. The lateral thyroid enlarge is comprised in part from cells of the ultimobranchial bodies, which originates from the 4th and 5th pharyngeal pouches. It is from these ultimobranchial bodies that the calcitonin-secreting parafollicular C cells arise. The median enlarge does not carry these cells. The lateral thyroid enlarge comprises approximately 1/3 of the total mass of the eventual developed thyroid gland. The anomalies in the embryologic development of the thyroid gland can lead to a variety of conditions, some of which can be pathologic. Now, the thyroglossal duct cyst. The normal development and subsequent obliteration of the thyroglossal duct are connected to that of the hyoid bone, which forms starting at the 7th week of gestation and functionally divides the thyroglossal tract into superior and inferior aspects. When the thyroglossal duct does not completely obliterate and the epithelial duct cells remain, a thyroglossal duct cyst may arise from a persistent connection between the thyroid gland and the foramen cecum. This scenario typically presents as a painless midline neck mass at or near the level of the hyoid, although it can be found near the base of the tongue or at the thyroid gland proper. Occasionally, these cysts can become infected from oral bacteria from the tongue and can also form fistulous sinuses to the skin. The cyst trunk procedure, originally described in 1920, is the surgical treatment of choice for thyroglossal duct cysts that become chronically infected. A number of modifications have been described, but the key component of the procedure involves excision of the entirety of the cyst and surrounding thyroglossal duct tract, including the central portion of the hyoid bone. Resection of a small portion of the tongue is no longer thought to be necessary in the majority of the cases. Now let's talk about the ectopic thyroid tissue. The aberrant thyroid tissue can be found anywhere along the normal path of the development and descent of the thyroid gland, from the foramen cecum down to the anterior mediastinum. The development of an undescended thyroid can lead to the formation of a lingual thyroid gland near the base of the foramen cecum. This abnormal thyroid tissue is often associated with inadequate thyroid hormone production with subsequent goitrous enlargement, which in turn can lead to local compressive symptoms of the upper neck, such as airway obstruction and dysphagia. Surgical excision is occasionally necessary for these cases. The other common locations for ectopic thyroid tissue are along the path of the thyrothymic tract, which originates from the 3rd pharyngeal pouch and pulls along the inferior parathyroid gland and lower poles of the thyroid lobes along the descending path of the thymus gland. Foci of normal thyroid tissue along this tract are typically referred to as the thyroid rests. These rests can occur in up to 50% of people and are typically not thought to be pathologic findings in and of themselves, although they may occasionally be mistaken for pathologic lymph nodes or parathyroid glands. The rests either can be connected to the thyroid gland proper by a thin stalk or can exist as completely separate structures. Primary intrathoracic goiters are thought to arise from enlargement of intrathoracic thyroid rests. Surgical treatment of thyroid rest tissue may occasionally be indicated if clinically relevant. Examples of this include thyroid cancer requiring resection of a thyroid rest as a part of thyroidectomy or local compressive symptoms from an intrathoracic goiter.